Hello everyone, my name is Madison Marsh, the president and founder of the Whitney Marsh Foundation, and today I'm joined by Dr. Yurgelun to talk about pancreatic cancer during our series for Pancreatic Cancer Awareness Month.
Hi, my name is Matt Yurgelun. I'm a GI medical oncologist at Dana-Farber, and I split my time between standard GI medical oncology, treating people with pancreatic cancer, but I also work in our genetics and prevention clinic, where I help evaluate individuals with a strong family history of pancreatic cancer, coordinate their screening, and oversee their genetic testing as well.
What got you interested into the medical field, or specifically pancreatic cancer?
So I come from a family that has a specific inherited syndrome that predisposes to a number of GI cancers, including pancreatic cancer, a syndrome called Lynch syndrome. And that's what really led me into cancer medicine, GI cancer medicine specifically, and cancer genetics and prevention more specifically. So a lot of my interest has always come from families that know that there's some degree of inherited risk, whether you can define that risk or not, and then figuring out how to be proactive about putting together screening and prevention interventions.
So can you explain a little bit what it means to have like a familial risk in pancreatic cancer, and then how would someone even find out that they have it if they weren't certain about it before?
So there's two different ways that we conceptualize having familial risk. One is that you have a specific, identifiable, inherited genetic phenomenon, what some people might refer to as a mutation, in a gene that predisposes to cancers, which can include pancreatic cancer. So Lynch syndrome, which I mentioned before, is one such syndrome. Lynch syndrome is reasonably common. We think it affects about 1 in 300 people. Inherited alterations or mutations in the BRCA1 and BRCA2 genes are other common phenomena that can predispose to pancreatic cancer plus other cancers. And so if somebody is known to have an inherited alteration in one of those genes, that's one form of inherited or familial risk. The other form of familial risk that we think of with pancreatic cancer is for families that have really clustering of multiple pancreatic cancers in the family tree. We've historically labeled those families as having familial pancreatic cancer, which is really just meant to be a catch-all term for families that have this type of undefined clustering. Most families that are labeled as having familial pancreatic cancer don't have an identifiable inherited gene alteration to really explain this. And so those are really the two situations that we think of when we think about high risk for pancreatic cancer, screening, prevention, early detection efforts, those sorts of things.
So how would you knowing that you have a familial risk for pancreatic cancer impact your detection and your treatment of the disease?
So knowing that there's risk there, first of all, that should tip us off to do genetic testing. If somebody comes in, they're healthy, but they've had multiple close relatives affected by pancreatic cancer, that's somebody we should be doing genetic testing on or offering genetic testing to see if they harbor a specific genetic phenomenon that explains that history. The benefits there are that, one, if we find something like that, we can then spread that information to other at-risk people in the family. Two, it helps us kind of understand and quantify that risk in the first place. And three, it can tip us off to there being potentially other cancer risks that are maybe not limited to pancreatic cancer. But even for somebody who has a clustering of pancreatic cancers in their family and maybe has negative genetic testing where we don't find anything, again, we would still think that there's some degree of risk. Those are people where nowadays we think about implementing screening for pancreatic cancer. We usually will start that screening at age 50. Again, if people have multiple close relatives with pancreatic cancer, so that should that person have a finding that either shows that they've got a pancreatic cancer already in place or something that might be precancerous, we can hopefully intervene on that before they get sick from that.
So would that impact their treatment in the long term, or would that just be, initial diagnoses, and that's where the main line of familial risk comes into play?
It's a good question. If there are certain genetic features, it can impact how you treat a cancer if it develops. So, for example, I mentioned before the BRCA1 and BRCA2 gene alterations. We know that pancreatic cancers that arise in the setting of inherited alterations in BRCA1 and 2 respond differently to chemotherapy, and there's certain chemo agents, including a type of targeted agent called a PARP inhibitor. We know those cancers respond particularly well to those. They respond particularly well to platinum therapies. Pancreatic cancers that arise in people with Lynch syndrome often have a specific molecular phenomenon known as mismatch repair deficiency. Those cancers respond beautifully to immunotherapy, which is otherwise something that we've had a hard time getting much success with in pancreatic cancer. And so if there's specific genetic phenomena that can impact how we treat it. When we're finding a pancreatic cancer because of screening in somebody who maybe has a clustering of diagnoses in the family, but no defined genetic risk, it doesn't particularly impact how we treat it, except that we've shown that that screening can be very effective at finding these cancers very early. And so hopefully finding these cancers at a stage where surgery is on the table and therefore cure is hopefully on the table for these people.
Very interesting. What would you say in your research, since you clearly have a lot of interest and professional background and familial risk, what would you say is the most impactful research or maybe project that you've worked on in your life?
So from a pancreatic cancer standpoint, I would say the most impactful thing I've seen is just the benefit of screening and early detection. For people who have these genetic risk factors and or come from a family that has this clustering, this familial pancreatic cancer, for a long time now we've been recommending that people consider screening. And that screening is typically screening with imaging. We use specialized MRIs and or specialized types of endoscopies called endoscopic ultrasounds to give high-resolution imaging of the pancreas, typically once a year, typically starting at age 50. And for the longest time, what I've been telling people in these circumstances is that I believe in this screening, I think it works, but that I hadn't necessarily had long-term data to point to prove that it truly worked. And just within the past year and a half, there's been data put out from our group and others that have really looked at some of the long-term outcomes when you screen for pancreatic cancer in these settings. And the outcomes are really impressive. You know, what we've seen is that if screening picks up a pancreatic cancer in somebody with one of these genetic or familial high-risk circumstances, if screening picks up a pancreatic cancer, more than half of these are stage 1. And we rarely see stage 1 pancreatic cancer otherwise. It's extremely unusual for it to be found that early. But I think more importantly than just the stage, what we've seen is that the long-term cure rate in people where screening picks up pancreatic cancer, the long-term cure rate has been 73%. And that's not 100% by a long shot, but it's a number that's kind of out of this world for pancreatic cancer. And I think the people who had been skeptical about the benefits of screening for pancreatic cancer over the years before these data, you know, might have said, hey, it's a bad disease, you might find it a little bit earlier, but the end result's going to be the same. And these data really fly in the face of that. These data show us, yes, you can find it early, but just as importantly, finding it early truly gives people a chance to have a cure and to have a far better outcome. And so that, you know, I don't think we've fully solved how do you screen and who do you screen, but it's at least given us pretty strong proof of principle to say that screening is possible, early detection is possible, and it makes a difference. Now it's on us to figure out how do we do that better.
Wow. How do you think some of these multi-cancer early detection tests are going to come into play with early detection? Because we've seen a lot on both sides of maybe the positives that it can bring. So what do you think? How is it going to impact the way that we test patients?
So all of the benefits that I mentioned in screening for pancreatic cancer are great. You know, those benefits come from pretty advanced tests such as MRIs, endoscopic ultrasounds, and it really asks a lot of the person going through that screening to stay on top of it and put themselves through some intensive procedures and imaging. The fact that we've now shown that early detection is possible and early detection makes a difference tells us, okay, now we've got to figure out how to do this a little bit better. The current approaches to screening, in my mind, aren't particularly scalable on a large basis. It requires pretty specific expertise at interpreting the images, at performing the tests like the endoscopic ultrasound, and that's great for people who are able to access centers that have these technologies and have experts who do these procedures and tests. But from a public health standpoint, to really move the needle further, I think we need to leverage something like blood tests. And so that's where some of these multi-cancer early detection assays hopefully, you know, are the next step here. I think we've got a lot of work to do still to figure out how to use them. Do they work in this context? Can we weave them in to protocols where people are getting imaging? Can they take the place of imaging for pancreatic cancer early detection? So I think there's a ton of really interesting questions that need to be studied here. But I think the baseline step was figuring out, can you screen for pancreatic cancer effectively? The answer is yes. You know, screening makes a difference. Now we just got to figure out how to use technologies like this to move the field forward on a larger scale.
What do you think should be our next focus in pancreatic cancer, maybe looking towards the next 10 years? What should we be doing?
So I think that some of these advances in early detection and figuring out how to use them, and most importantly, I think figuring out how to use them outside of the major academic medical center setting is really the next frontier here. With some of the early detection advances that have been present, all of these are taking place at major academic institutions, which is great. That's where so much of this science happens. But I think we need to figure out, how do we bring this into the community? How do we reach people who might not have access to some of these major medical centers? Because those are the people who probably need this as much as anything. That plus just identifying who might benefit from this, who else has familial risk and genetic risk.
Is there anything that you think our audience should know about pancreatic cancer that you haven't mentioned, or anything that you want to leave them with for this Awareness Month?
I would say that pancreatic cancer is one that's really earned its nasty reputation, for sure. But at the same time, I think there really is a tremendous amount of hope that we're seeing from new advances in treatment, new advances in early detection. And so its reputation is unfortunately very well earned, but that doesn't mean that that's what the future holds.
Thank you so much for being here with us today and sharing your insight and your research. We hope that you all learned a lot today about pancreatic cancer during our Awareness Month. This is your reminder that if you believe that you are experiencing symptoms, to go reach out to a physician and receive care today. Thank you so much for joining us in our fight against pancreatic cancer.